Alright, so right now, this video, I'll finish up the rest of NBME 18 Block 2. We'll look at everything from 70 to number 100. And then tomorrow I'll continue on with Block 3 and Block 4 around the same time as right now, noon NYC time. And just finish up NBME 18. After that, after NBME 18, I think the next NBME that I have that's ready to be discussed is 21. I've already done videos on NBME 20 and 23, so I'll talk about 21 as well. And then from there we'll see. I've gotten a couple emails about video suggestions as for ways of studying or how to tackle various other difficulties a lot of people are having, common difficulties that a lot of people are having when they're studying. So I guess I'll share some tips about that, and that should be it. I just gotta finish up the first aid playlist for step 1, and then I'm gonna start preparing a bunch of stuff after that for CK. So right now we're looking at question number 70. So this one says, yeah, that's also another topic I have to make a video on. That's a pretty complicated topic, how to remember everything. But generally speaking, the quick answer would be like repetition, and the same advice I always give, which is to always talk to yourself about the things you studied in a given day, right? So like if you studied, like the last video I did for first aid, we were looking at the psych, ego defenses, right? So after you finish studying all the psychology section of this chapter, which is mainly just ego defenses, you should make a list of all these keywords, reinforcement, punishment, extension, acting out, denial, blah blah, and then you should be able to define those things and talk about them without the book in front of you. That's literally the only way you're actually going to master something, because if you can't explain something without looking at the book, you haven't quite memorized it yet, and by the time you become comfortable at doing it, then you're much better at it. But I'm definitely going to make a video on a couple of these key questions that people have been asking in emails. It'll be a lot easier to just put everything in one place so that that guidance is there. Alright, so let's get started with this. So question number 70. A 15-year-old girl is brought to the physician by her mother because of lack of improvement in facial acne. Topical clindamycin and benzoyl peroxide therapy was initiated 3 months ago. Physical exam shows severe acne vulgaris. The patient says, "Please help me, the medication you gave me isn't working, and I'm embarrassed to go out with my skin looking like this. She has never been sexually active. Which of the following drugs is the most appropriate treatment at this time?" And you look at all your answer choices, and one that should definitely ring a bell immediately is the isotretinoin, right? The vitamin A analog that is used, right? So retinol is vitamin A. So think retina, used topically for wrinkles and acne, right? The A should stand for acne. Found in liver and leafy vegetables. Use oral isotretinoin for severe cystic acne. And then you could use all transretinoic acid to actually treat acute promyelocytic leukemia. They go on to tell you more that how, vitamin A is pretty teratogenic, so you have to have a negative pregnancy test, and you have to prescribe 2 forms of contraception if you're going to be taking isotretinoin. Right, so that's something that would be further added on to this patient's regimen if she continues to take this, or if she ever plans to get sexually active. And generally speaking, you don't wait for the patient to get sexually active. She's 15. Chances are she should be menstruating already. So you would not just give the isotretinoin to this patient. You would also prescribe contraception, 2 forms of contraception to the same patient as well. Even though she's not sexually active right now, there's no saying when she will become sexually active, and if she ever gets pregnant, you don't want to risk the chance of the teratogenic effects that it can have on her. So that's that. Number 71. A 66-year-old woman is brought to the emergency department by her daughter because of a 2-day history of fever, flank pain, pain with urination, and nausea. 10 days ago, she was admitted to the hospital for similar symptoms and was diagnosed with acute pyelonephritis. She was discharged with instructions to take oral ciprofloxacin. After a 3-day course of IV ciprofloxacin resulted in improvement. She also has hypertension, hyperlipidemia, and osteoporosis. Current medications also include alendronate, calcium carbonate, and ezetimibe, hydrochlorothiazide, and simvastatin. Her temperature is 102.4 and blood pressure is 130/80. The most likely cause of this patient's current condition is an interaction between her current oral antibiotic and which of the following medications. So when you get questions like this, there's only two things, right? Either someone's taking some kind of chelating agent, or they're taking a medication that has an effect on the P450 stuff. She's taking ciprofloxacin, and it worked initially, but then it seems like it's not entirely, working out for her. And you look at all the other medications she's taking, alendronate, right? Alendronate is just a bisphosphonate. You have to remember the onate for all the bisphosphonates, and that has nothing to do with her antibiotic. It doesn't have an effect on P450 or any kind of chelation. Calcium carbonate does, and that was the issue. Ezetimibe, hydrochlorothiazide, and simvastatin. Simvastatin and ezetimibe, those two are both medications that are related to cholesterol, and none of those really have an effect on medication metabolism and stuff. And hydrochlorothiazide is a renal medication that really just causes hyperglycemia stuff, but it's not going to cause any kind of ineffectiveness. So calcium carbonate, that's actually the mildest of all your antacids, and it actually causes hypercalcemia and rebound acid, right? It makes sense because it has calcium in it, so you can always remember that. It can also chelate other drugs like her antibiotics, making it ineffective. All right. So page 433 discusses that little topic right there. So you have aluminum hydroxide, calcium carbonate, and magnesium hydroxide. You need to remember what their main side effects are. Aluminum hydroxide has minimum amount of feces, right? So that's great. However, that's the opposite of what you actually end up, wanting. So aluminum hydroxide has constipation, minimum feces, hypophosphatemia, osteodystrophy, proximal muscle weakness, and seizures. And CHOPS is the way they tell you to memorize it. The way I memorized it was I did this thing. So I wrote A is the first letter, so it's the head of the alphabet, right? And that's where it starts with A. So that A should remind you the head, which is for seizures. The L in ALU, the L is like your vertical spine, so that's osteodystrophy. And the U is like when you flex your arms, right? So that's your muscle weakness. And that's kind of something I just used to memorize this. And it's aluminum hydroxide. I couldn't fit the more stuff here, but generally speaking, the H here, that H would remind me of hypophosphatemia. That's just something that worked for me per se. It's not really a real thing. It was pretty much a personal way of memorizing it, I guess. But everything else already had a thing, right? The minimum here is to remind you of the minimum feces, which is constipation. A, L, and U are supposed to remind you of A for the head, seizures, L for your spine, osteodystrophy, U for a flexing arm, proximal muscle weakness, and H here for phosphate, hypophosphatemia. So that's aluminum hydroxide. Magnesium hydroxide is the opposite of aluminum. This actually causes diarrhea, must go to the bathroom, right? Must go to. And it causes hyporeflexia, hypotension, and cardiac arrest is the actual real issue here, but not the biggest problem, I wouldn't say. Let me see. And then the one our question is about is the calcium carbonate, right? So this is the mildest of the three choices. However, it can chelate and decrease the effectiveness of other drugs. So oftentimes, if your patient does have GERD and they tell you they take antacids, sometimes you have to ask, because most times they won't even mention it, but you have to ask that, whether or not they take antacids. Once you find out they take antacids, you have to tell them, like, all right, so don't take it while you're on this antibiotic or whatever other medication you're giving them. All right. It's a common thing to get sick and have a cold and require antibiotics. And when you get your antibiotics, you have to make sure that when you're on the antibiotics, you're not taking any of these chelating agents. 72 is actually really easy, straight up sketchy micro stuff for the most part. A 2-month-old female infant is admitted to the hospital because of a temperature of 102 F, vomiting, diarrhea, and dehydration. So now, before you even move on, you need to start thinking of all the things that can possibly cause a 2-month-old to have diarrhea. Examination of a stool suspension by negative stain electron microscopy shows viral particles with a wheel-like shape, so some kind of virus is doing it. Which of the following best describes the physical and chemical properties of the virus involved? Now you should know immediately when you're done with that rotavirus is the most common cause of infantile gastroenteritis. So this had to be rotavirus, and rotavirus is a reoviridae, right? It's from that class, and reovirus is always called repeatovirus because it's actually has its double will actually act up. So I'll wait till it reconnects. No big deal. Alright, looks like we're back. Let's just make sure this is HD. Alright, so as I was saying, repeatovirus is the one that's double-stranded, right? Reovirus, rotavirus. And since it's double-stranded, you automatically knock out everything else. You're just between A and B. Now, between A and B, they told you that it's got a wheel-like shape on electron microscopy. So that could, you could use that information to be like, alright, so it's probably not helical, it should be icosahedral, and just go with it. But there's more to help you. There's also the fact that if you remember segmented versus linear, right? Reovirus is actually segmented, so that also helps you. Like the answer choices here were very nice too. So if we look at it, 173. So this is your Rio Grande pricks, right? The rotavirus thing, they tell you here. You see how they're describing this as wheel-shaped? It's not really wheel-shaped, but whatever. So this is your double-stranded RNA. So you see how this looks like a DNA? That's your double-stranded RNA right there. It's segmented, which is why you have all these boats. I believe it's got 11 segments, so you have 11 boats here. There's live vaccinations for it. It's the #1 cause of infantile gastroenteritis. This portion in the bottom left is showing you explosive diarrhea in a sense. This guy here is dehydrated, right? It also causes Colorado tick fever, I believe, something like that. So both of those things are also put into the same image, right? And you have your naked statue of David here. All right, so that's pretty important too, because it is naked. And that's generally it for that, right? So it's not that bad, not a difficult one to work with. If you look at the segmented virus thing, remember the Bohr stuff, right? So here, Bohr, right here, right? B-O-A-R, Bohr. So bunioviruses, orthomyxo, arena, and reovirus. 10 to 12, 11 segments, whatever you want to remember it as. And then rotavirus, let's see, yeah, reoviruses. So you have your Colorado tick fever and rotavirus, two different guys. Alright, so they're both in the same image. And that's generally not that hard. Sketchy micro definitely made it a lot easier to answer questions like this. I don't know how people used to do it before Sketchy micro was a thing, but definitely much easier now. Then 73. An investigator is studying epithelial repair in the small intestine of an experimental animal. The plan is to identify the location of the most active cell division. This cell activity is most likely to be found in which of the following regions? So, small intestine regeneration, right, that comes from the crypts of Libercune. So as soon as you see these answer choices, when you see answer choice A and they say base of the crypt should remind you of crypts of Libercune. These crypts have stem cells that replace enterocytes and goblet cells, and they have Paneth cells for secreting defensins, lysozyme, and TNF. Brunner glands just secrete bicarbonate in the duodenal submucosa, and Peyer's patches are lymphoid in the ileal submucosa. And you need to know that histology. When I did my GIT videos, in my first aid, I actually have a bunch of really nice images for that histology. So first aid itself on page 356 tells you all the general, the breakdown of the layers and the general histology, and they have these pictures here to really make you, make it easier for you to understand the general histology that you have to know well, right? Because that's something that they can describe in a question. You got to catch it. You got to know how to deal with it. You got to know where in your GIT you are based off of what is being given. So if they ever tell you you have glands in the submucosa, right, that's usually your duodenum. Or if they tell you something about the Peyer's patches, then you're in the ileum. Those two are pretty identifiable. I went on to describe a bunch more, right, with many more histo images as I was talking about it in my GIT videos. And the most important thing was the crypts of Livercoon right here. Right, so the crypts of Livercoon, you see, starts from the duodenum, you find it in the jejunum, right, and then you also find it in the ileum, and you find it in your colon. It's everywhere. Right, so this thing, they tell you it contains stem cells. That's the guy that actually regenerates anything after any kind of injury, maybe because you ate something very acidic or whatever might have happened. Maybe you had some gastroenteritis, and you're able to recover from that. Okay. 74. A 55-year-old woman who is a physician is admitted to the hospital because of a fractured femur sustained in a motor vehicle collision. 2 days after admission, she develops tachycardia, restlessness, diaphoresis, and anxiety. She says that vague shapes are coming out of the walls. Which of the following is the most likely cause of this patient's current condition? Now, in block 2, I haven't yet gotten a question wrong. Remember that for NBME 18, right, I am writing down every time I answer the question incorrectly. And did I have anything wrong so far? Let me see. No, the last question I got wrong was number 41. Yeah, 41 I got wrong, and that was the 4th question I got wrong. So far, although some of these questions might look intimidating and difficult or anything like that, they were definitely doable if you're actually ready for step 1. Right? And right now, looking at this question also, before you even look at your answer choices, you should know anyone who came to the hospital, was hospitalized for a couple of days, and then has symptoms of tachycardia, restlessness, and sweating, and anxiety, this is alcohol withdrawal. That's like straight up alcohol withdrawal. So she was hospitalized for 2 days and could not drink, so now she has alcohol withdrawal symptoms. She's currently in the 12 to 48 hours period where she's having visual hallucinations. Remember that alcoholism downregulates inhibitory GABA A receptors and upregulates NMDA receptors. Very important little topic. So we have a couple pages we should look at because I do want to review this. So 6:15, 17, and 18. Let's take a look. So 6:15, psychiatric emergencies. They tell you right here, what was on 6:15? Your delirium tremens, right? Delirium tremens. Alcohol withdrawal occurs 2 to 4 days after your last drink, classically seen in a hospital setting when the inpatient cannot drink. So you get the altered mental status, hallucinations, autonomic hyperactivity, anxiety, seizures when it gets really bad, and depending on how addicted you are to alcohol. And generally speaking, the way to help them is to give them benzodiazepines, because it uses the same receptor as alcohol, so it kind of gets rid of the withdrawal symptoms. These are things we're going to talk about as we keep going, right? Because we're right now in the psychiatry section in my first aid playlist, so there's a bunch of really important, nice images to help you be able to differentiate between things like anticholinergic poisoning, serotonin syndrome, neuroleptic malignant syndrome, and cholinergic toxidrome, which is basically your organophosphate poisoning, right? Really important lecture. When we get to that, that's going to be a good topic to talk about. But right here on the next page, we can see alcohol, right? So time from the last drink determines what symptoms you're going to have in the inpatient setting, right? And you can see the first few things right here. You're seeing your tremors, agitation, GI upset. They might even have diarrhea. 6 to 48 hours into not drinking, so 2 days, withdrawal seizures, right? And 12 to 48 hours, within the same 2 days, you get alcoholic hallucinations. After that, the withdrawal gets really bad, and you can actually end up getting delirium tremens, which is what we just looked at, and you need to give them benzodiazepines, right? So very important thing. At the end here, they talk about alcoholism as a physiologic concept, and this is a very important thing to really make sure you understand. So I'm going to read it here because I always talk about repetition. This is something you need to memorize and know. So acutely, alcohol potentiates inhibitory GABA A receptors, leading to sedation, okay? So chronic alcohol leads to a downregulation of those GABA A receptors. When alcohol is no longer being consumed, the downregulated fewer GABA receptors are so insensitive to GABA that the typical amount of GABA you produce has little effect, leading to physical withdrawal symptoms since GABA normally inhibits neural firing. Now you cannot inhibit neural firing, so you have anxiety, tremors, agitation, all of that, because you just can't get yourself to naturally feel sedated, nice and relaxed, go to sleep, that kind of thing. So GABA desensitization results in unopposed excitatory neurotransmission, which can eventually lead to having seizures. Alcohol also inhibits excitatory NMDA receptors in the brain. So chronic exposure upregulates NMDA receptors, right? Because you were not activating enough of them, so your body was like, let's put more receptors out there, maybe they'll activate. When alcohol is no longer consumed, maybe because you're hospitalized for 2 days, the excessive NMDA receptors will be more active than normal, contributing to the delirium tremens and excitotoxic neuronal death. Alcohol withdrawal causes a surge in release of excitatory glutamate, which activates NMDA receptors. Now, when you're working with a patient who needs help getting through this alcohol addiction, you have to keep working with them until the number of GABA A receptors and NMDA receptors has been brought back to what it normally was, when it finally goes back to being regulated, right? Because if you don't, then they're still going to be addicted and they're still going to have withdrawal symptoms, and it's going to be very difficult for them to actually deal with it. Right? So always remember what's in this table right here, right? Acute intoxication, you upregulate GABA A, you downregulate NMDA, so you end up having your body responding by downregulating the number of GABA receptors because you activated too many of them. Right? You activated too many GABA receptors, so your body gets rid of some of them, and you were not activating any NMDA receptors, so your body makes more of them. When you stop drinking, you get the opposite effects. Right? So you're not sedated anymore, you're anxious and agitated, you're not relaxed anymore, you're actually at the point of possibly having seizures. Okay? So that's a very important concept. Alcoholism is really big, very high yield, not only for the exam but also in real clinical practice, and you should make sure you know it inside out. So that was alcohol withdrawal. 75. A previously healthy 20-year-old woman comes to the emergency department because of a 2-week history of fever, shaking chills, headaches, fatigue, and joint and muscle pain. She recently spent the summer working as a lifeguard on Long Island, New York. She has never traveled outside the USA. She underwent splenectomy for injuries sustained in a motor vehicle collision at the age of 6 years. Her temperature is 102.4. Physical exam shows no other abnormalities. A peripheral blood smear shows small intraerythrocytic rings. And this is probably the 3rd or 4th time they're talking about this in the same NBME. And all NBMEs love talking about this. I mentioned it in the last video too. Plasmodium, Babesia, Lyme disease, those guys, the protozoa. They love asking questions about protozoa because all of us medical students work really hard to master bacteria and viruses, right? So now they're like, all right, let's ask questions about something other than bacteria and viruses. Like everyone already knows about bacteria and viruses pretty well, so why keep asking about bacteria and viruses, right? So let's switch it up. And protozoa take some time to memorize, just like bacteria and viruses, so you really got to make sure you put that effort in. This intraerythrocytic ring is something you see in multiple things. There's 2 of them specifically. So they cancel out the other one. They tell you the results of polymerase chain reaction test for Plasmodium is negative. So it's not Plasmodium. This patient most likely acquired causal organism via a bite from which of the following? And you look at your ask choices, and a lot of people were very quick to pick mosquito, but mosquito would be the correct answer if it was Plasmodium, right? Because that's malaria. Here, after that, you're left with a couple other ask choices. Not bedbug. We already learned from another we already learned from another NBME question that bedbugs carry Staph aureus apparently, right? So they can cause skin infection. The black fly is the one that was responsible for causing the river blindness, and that's not what's happening here. Mites are more so for things like rickettsia, and those bugs. So you're really just left with a tick, right? So let's take a look at what's happening. 162. So Plasmodium, you can see how this there's that ring form it has. It's the trophozoid ring form. They told you it's not that, right? Because they did the PCR analysis and they figured out it's not malaria. The other ring form is this one right here in Babesia. It looks very much the same. There's really no major difference. This one is just the This is just the ring form of Babesia. The other thing is the Maltese cross. So those are 2 things you see pretty commonly in patients who are infected with Babesia. And what becomes even a bigger deal with Babesia is that it's carried by the same tick, the Ixodes tick, which carries Borrelia for Lyme disease, right? So you can see On the bottom right here, this is the image for Babesia. These are your Babesia babes over here. And everything in this image is pretty critical for what Babesia does. One of the major things being the fact that there's no spleen. Right, so this is the spleen rip in his shirt, right? Increased risk of severe disease and asplenia. Right, and then most patients who have Babesia often also have Lyme disease, so you got to remember that, and you have to treat both things. The treatment for this is your atovaquone, so atovaquone, and you add azithromycin as well. So coming back to here, that was just tick as your answer choice, and you'd be done with that. Alright, 76. A previously healthy 20-year-old woman has had a palpable lump in her right breast for the past 4 months. She has not had pain, swelling, or a nipple discharge. The lump is smooth, firm, round, mobile, non-tender, and well delineated from underlying tissue. There are no changes in the skin around the lesion. Which of the following is the most likely diagnosis? Now, when you look at your answer choices, if you've been studying this topic at all, then even if you're not 100% sure, you should feel pretty comfortable in thinking it's probably C, a fibroadenoma. However, at the end of the day, most students will end up between B or C. You know this is not a cancer. It's not breast cancer. She doesn't have breast cancer, so you can knock out A. It's not gynecomastia because she's a female and she doesn't have any prolactinoma or liver disease. And it's definitely not mastitis. She doesn't have inflammation of her breast either. So between cyst and fibroadenoma, everyone was all over the place. There was no one answer choice that was picked more commonly over the other. But the main concept here is really being able to differentiate. Fibroadenoma is the most common benign tumor in a woman under age 35. Cysts was a bait of an answer choice. Fibrocystic changes are the most common in premenopausal women, just like this one, 20 to 50 years old of age, but it would have breast pain and be bilateral or multifocal. Very important difference to make sure you know. Right, so let's take a look at this, page 708, reproductive. So this is page 635 of First Aid 2019. They start talking about breast pathology, right? And you can see our correct answer for our question is a fibroadenoma. It's a benign tumor, what she has. Right, so well-defined mobile mass, increase in size and tenderness with increase in estrogen, so during menstruation or prior to menstruation, and then risk of cancer is not usually increased. The other answer choice that people fell for was the cyst, but fibrocystic changes are actually, a different identity. These things present with premenstrual breast pain or lumps, often bilateral and multifocal, so that was one thing to cancel out cyst. And then the non-proliferative lesions include simple cysts, which is fluid-filled, duct dilation, blue dome, papillary apocrine change, stromal fibrosis. Risk of cancer is usually not increased, but there's two subtypes. The epithelial hyperplasia one has an increased risk of carcinoma with atypical cells, whereas the sclerosing adenosis one has a slight increased risk of cancer, but not too much. Regardless, the chances of cancer with cyst changes are higher than the benign tumors. So really, you gotta make sure you know that difference between the two. The other answer choice was the mastitis, right? Lactational mastitis or fat necrosis. Both of these things are pretty common. Fat necrosis happens from any injury to the breast tissue, and it doesn't have to be injury from anything traumatic. It can even be injury from just having sex. Lactational mastitis occurs during breastfeeding, so it's called lactational mastitis, and it's usually just because of bacterial infection through the cracks of the nipple from breastfeeding. Right, so really straightforward stuff. She wasn't going through either of those issues, and gynecomastia, right, would have to be related to one of these things: some medication, some disease, some liver issue. Any of these things would cause gynecomastia, but we don't have that in our question either. All right, so really just a good question to help you understand the difference between cysts and fibroadenoma. 77. A previously healthy 17-year-old boy is brought to the emergency department 1 hour after having a syncopal episode. He has had fever, nausea, muscle aches, and progressive confusion during the past 12 hours. His temperature is high, palpable blood pressure is 80. Physical exam shows a rash on the lower extremities and feet. His leukocyte count is 26,000. Blood and cerebrospinal fluid cultures grow an oxidase-positive, gram-negative Diplococcus. The family reports that the patient's older brother had a similar infection at the age of 16 years. The patient and his brother most likely have which of the following immune system disorders? So this gram-negative Diplococcus that's oxidase-positive, this is actually Neisseria meningitis, right? And the description they're giving of this guy, his muscle aches and whatnot, the muscle ache is actually going to be the muscle ache behind his neck, not just anywhere in the body. But they didn't give you that, they just said muscle ache. But the main point was they're talking about Neisseria meningitis, and if his brother had it too, then the fact that these guys are practically having recurrent Neisseria infection, you just start thinking of complement deficiency, terminal complement deficiency, and that's answer choice B. Right? You have to know this stuff. It's a very simple topic, not something you need to study too hard. Just a simple topic you keep in the back of your mind and remember it. Early complement deficiency, C1 to C4, especially C3, is seen in patients with lupus. Terminal complement deficiency, from C5 to C9, pretty much the whole thing, is seen in patients who get Neisseria infection over and over. Okay, because they can't fight it. You need MAC to be able to fight it, and if you don't have MAC, then MAC deficiency ends up causing you to have more and more Neisseria infections. The other answer choices here, ADA deficiency, right? Adenosine deaminase deficiency is the autosomal recessive form of severe combined immunity deficiency and would have recurrent viral, bacterial, fungal, and protozoal infections. ADA deficiency is actually discussed in the beginning at biochemistry, and then they talk about it again in immunology when they discuss SCID. Hyper IgM syndrome is a class-switching defect. A class-switching defect where you have low IgG, A, and E, right? Hence called hyper IgM. All you have is IgM. So patients have severe pyogenic infections and opportunistic pneumocystis pneumonia and cytomegalovirus infections. Not what we're seeing with our patient. Hypogammaglobulinemia is just another name for Bruton's A gammaglobulinemia, where you don't have any globulins. So these also have bacterial and enteroviral infections due to lack of all Ig. Our patient doesn't have that. Our patient isn't getting all kinds of bacterial and viral infections. Our patient is only getting Neisseria infections, so that's related to the terminal complement, and that's about it. The other thing I was going to say real quick was, in this question over here, when they tell you she lost her spleen, so on NBME, it's a very weird topic. Generally speaking, if someone had a splenectomy, especially in a hospital setting, then they will be vaccinated, right? That's part of the splenectomy procedure. They're going to be vaccinated against most of those encapsulated organisms. Now, this question per se wasn't about encapsulated organisms, so it was okay here, right? This question was about Babesia, and Babesia causes more severe infection in asplenic patients. That was fine. But NBME tends to have a lot of questions where they'll talk about an asplenic patient getting infected by something encapsulated, and that just means that you can't really assume that they were vaccinated after the splenectomy. For step 1, I believe you can assume it, right? Because realistically speaking, no one gets a splenectomy and doesn't get vaccinated. It's just not how you finish the procedure. It's part of the procedure. For NBME, though, for some reason, they don't want you to really assume that, because I've seen a lot of questions on NBME where the patient got a splenectomy and then later on got infected by some kind of encapsulated organism. You're just like, how? Why? Why was this patient not vaccinated? So just be careful with that. 78, this was actually not too bad either. Very straightforward, simple math. A retrospective study is conducted to assess the incidence and outcome of subarachnoid hemorrhage in a Midwestern state. The annual incidence of this condition is 15 per 100,000 people. Right, so that's the incidence. And the annual mortality rate is 6 per 100,000 people. So when you read this, right, 15 people get infected and 6 die, that means 6 of those 15 must be dying, right? Because it's not going to be someone that wasn't one of those 15. Assuming that the incidence remains constant, which of the following is the case fatality rate for this condition in this state? Case fatality rate is a straightforward topic of how many people that got sick actually died, right? Just the percentage of people that got sick that died. So there are 15 cases, of which 6 of them seem to die, so the rate is 6 out of 15 times 100, or 6 out of 15 would just give you the decimal aspect of it, and that gives you D. 6 out of 15 is 0.4, right? So that's 40%. And this actually is in first aid as well. They talk about it. They give you the straightforward, simple explanation of case fatality rate all the way at the bottom here. Can't remember if this was always there, but this isn't something you really even need to be in the book. It's something you should be able to derive on your own. So if 4 patients die after 10 cases of meningitis, 4 out of 10 is 0.4, that's 40% here. And same kind of topic, very straightforward calculation, nothing complex about that at all. So now here's 79. A 35-year-old man comes to the physician because of severe midline back pain during the past 4 weeks. He has gained 8 kilograms during the past 6 months. Visual field testing shows decreased peripheral vision in both eyes. An X-ray of the chest shows compression fractures at T10 and L1. There is a healing left rib fracture posteriorly at T6. And imaging studies show you a pituitary macroadenoma. The most likely cause of this condition is a tumor producing which of the following hormones. So you know it's a hormone being produced from your pituitary, and you look at your answer choices, and then you imagine this, the way this patient looks. This patient has the Cushingoid habitus, right? He's gaining weight. That was alone good enough to understand that this patient actually has Cushing disease, not syndrome. It's Cushing disease if it's actually a pituitary adenoma causing the Cushing, right? Everything else is Cushing syndrome. This guy has Cushing disease. ACTH is going to be super high in him. And in this case scenario, you can do the dexamethasone suppression test. You can do, my phone is actually dying. Let me connect it. You could do the dexamethasone suppression test. You could do the, whatever the other, what was the other one? The upregulation test, not the suppression one, whatever it was. You can do both of those guys. Let's take a look at it, and you're going to see that it actually has an effect on the negative feedback aspect, right? So CRA stimulation, right? Corticotropin releasing hormone stimulation is actually going to cause an increase in ACTH secretion, and dexamethasone is going to cause a decrease in ACTH secretion. And the reason it's going to happen, you're going to have adequate suppression or an increase depending on which test you do, because this patient has Cushing disease. The pituitary is a part of the hypothalamic pituitary axis. So when you give medication or hormone that's supposed to work on the axis or affect the axis will actually respond, as opposed to ectopic secretion, right? If your cortisol secretion, if your Cushing syndrome is because of something in your lungs, then that's not going to respond to anything you give to the patient. That's not part of the HPA axis. 80, a 5-year-old girl is brought to the physician because of a chronic cough that is worse at night and productive of thick green sputum. She has a history of intermittent cramps in the right lower quadrant of the abdomen and frequent respiratory tract infections. Her 8-year-old brother is healthy. Physical exam shows clubbing of the fingers. There is hyperresonance on chest percussion. So we've already talked many times about what hyperresonance on percussion is supposed to be about and all the other chest sounds, lung sounds. Diffuse, medium-pitched inspiratory crackles and scattered pulmonary wheezes are heard during expiration. A chest X-ray shows evidence of diffuse hyperinflation, which is especially prominent in the right upper lobe. So you should have a pretty good idea of what's wrong with this patient by now. Which of the following best explains the likelihood of this patient's brother being a carrier of this condition? And this is a really nice question because everyone always forgets this fact about autosomal recessive conditions. So this is a question about cystic fibrosis. It was very evident from everything that's happening to this 5-year-old girl. And if we go back and look at autosomal recessive inheritance, then everyone reads this, and then a lot of people actually don't even read it. I know a lot of students that actually didn't really pay attention to this page at all, but this is a very good page. It tells you everything you need to know about general inheritance rules. So autosomal recessive, with 2 carrier parents, on average 1/4 of children will be affected, right? Half of the children will be carriers, so these 2 guys, and 1/4 of the children will be neither affected nor carriers, because both parents have to be carriers for anyone to get infected anyway, right? Because it's an autosomal recessive disease. Often due to enzyme deficiencies, which is pretty true. Almost all enzyme deficiencies are autosomal recessive, usually seen in only one generation, commonly more severe than dominant disorders. Patients often present in childhood. Increased risk of consanguineous families, so families where cousins are getting married or something. And unaffected individuals with affected sibling has 2/3 probability of being a carrier. Okay, so 2/3, where is that 2/3 coming from, right? That's something that a lot of people fail to understand. So this girl has cystic fibrosis, which is inherited autosomal recessively. Autosomal recessive diseases have a 2/3 chance of being a carrier, and the 1/3 is the person who is unaffected. Okay, unaffected. So that's the guy right there, right? Unaffected individual with an affected sibling. So unaffected individual is this guy. The affected sibling is this guy. The other two are carriers. So 2/3 probability of being a carrier is talking about the gray boxes, right? Of the 3 gray boxes, all 3 of these guys are unaffected. They don't have cystic fibrosis. Being unaffected but having someone in your family who does have the disease means that you have a 2 out of 3 chance of being a carrier. Right? Very straightforward. Make sure you understand that. You don't want to spend time coming back to this again. So if this is you're the guy who doesn't have the disease, and you have a sibling who does have the disease, then that means that you could actually possibly be this one or this one too. So it's 2 out of 3. 3 gray boxes, one of those 2 is a chance of being a carrier. Alright, so you have to remember the concept of 2/3 when it comes to autosomal recessive diseases, and that was answer choice E. A lot of people were very, very confused because they didn't remember the 2/3 concept at all, and they didn't know what to pick because everything else doesn't fit, and 2/3 is almost never an answer choice for anything of this manner, right? That's what you would think if you haven't actually studied the fact that autosomal recessive diseases have a 2/3 chance of being a carrier. Alright, so make sure you understand that, make sure you get that right. That's like a straight answer and move on kind of question if you can recall that one fact. Alright, so now next question. Where was I? Okay, 81. A 2-pound 5-ounce male newborn delivered at 28 weeks gestation develops rapid breathing, grunting, and subcostal retractions shortly after birth. Coarse rhonchi are heard on auscultation of the chest. A chest X-ray shows fine densities with a reticular granular appearance bilaterally. Arterial blood gas analysis on room air shows decreased pH in PO2 and increased PCO2. A deficiency of which of the following is the most likely cause of the pulmonary disorder in this patient? So you can understand from the first sentence that this was neonatal, right? Neonatal respiratory distress syndrome, because this is actually a baby that's born too early, right? They tell you it's actually a very tiny baby, very underweight, and 28 weeks. So definitely born a little too early. And when you're born too early, 28 weeks is actually that cutoff point at which point surfactant is done being made, right? You need another 2 weeks to be completely done with at least the amount of surfactant necessary for survival. And then after being born, they can make more surfactant anyway. But 28 weeks was a little too early. So this was neonatal respiratory distress syndrome. And the answer choices here would really just be between sphingomyelin and B, right? B or D. That's it. The other things don't really have anything to do with surfactant. So let's take a look at that topic right here. Respiratory. Neonatal respiratory distress syndrome. They love asking questions from this page. In step 1, it's very high yield, and NBME enjoys this topic as well. So here we have neonatal respiratory distress syndrome, surfactant deficiency. You're going to have high surface tension, and you get alveolar collapse, leading to a ground glass appearance of the lung fields. Right, so the lung fields have a ground glass appearance. Prematurity was the cause in our patient, but maternal diabetes could also cause it. C-section delivery could also lead to neonatal respiratory distress, because with C-section delivery, you have a decreased release of fetal glucocorticoids, because C-section delivery is less stressful than vaginal delivery to the baby. Treatment is maternal steroids after birth and exogenous surfactant for the child. So if you look at this graph here, you can see by 30 weeks, the amount of everything being made, is starting to reach at a pretty good point. But before 30 weeks, you're still at a pretty stable plateau. It's not good enough. It's not good enough. and being born at full maturity, right, you have a lot more, triple the amount that they would have had at this level. Alright, so that's something that you want to make sure you understand. Now, the other topic that's really big deal for this is the fact that oftentimes you'll get confusing questions like the ones below here, where they did therapeutic supplemental oxygen for this baby, right, to try to help the baby out. And that therapeutic supplemental oxygen can actually injure the baby in the long run. You can end up having retinopathy of prematurity, intraventricular hemorrhage, or bronchopulmonary dysplasia, right? Any one of these things. And on this graph, they tell you lecithin is the one that's super high. That's the guy you really, really need. Sphingomyelin, not so much the most significant guy. So lecithin is also called dipalmitoyl phosphatidylcholine. It's a lipid, just like sphingomyelin is a lipid also. So you have to make sure you understand that. UWorld also asks questions where they put the graph like this, and they put in answer choices, and you see they don't put lecithin as an answer choice. It's phosphatidylcholine. So you have to make sure you understand the different names of things. In first aid itself, they don't call it dipalmitoyl phosphatidylcholine, they just call it lecithin, so make sure you know. And that was just the answer here, B, dipalmitoyl phosphatidylcholine. That's the thing that's too low. So if the L is low, the ratio becomes low because the numerator becomes smaller. So you're going to end up having a low L to S ratio due to very low lecithin, which is also called dipalmitoyl phosphatidylcholine. Right? The ratio is depicted by this blue line here, which is increasing because the numerator is increasing. In immature babies or in neonatal respiratory distress syndrome in general, the ratio is going to be less than 1.5. More than 2 is healthy. Your lecithin should be double the amount of sphingomyelin, should even be triple the amount of sphingomyelin. If it's not, then you're going to have neonatal respiratory distress syndrome. It's raining pretty hard outside, and I'm actually kind of enjoying being able to study in the rain. It's nice with that background noise. Much better than the guy with his freaking saw machine. 82. Full-term newborn has respiratory distress. So again, another question on the same exact topic, right? Imaging studies show herniation of abdominal contents into the left pleural cavity. Maldevelopment of which of the following structures is most likely to have caused the defect of the diaphragm? And you really need to know this topic too. It's another one of those just memorize it, know it, never get it wrong kind of topics. So this is actually D. It's an issue with the left pleuroperitoneal membrane, and you just have to know it. Page 719. So it's on actually the same area right here. So this is what happened to our baby. Our baby has a congenital diaphragmatic hernia. The intestines went through the diaphragm and came up here, and now there's no space for the left lung to actually, do its thing, so the left lung collapsed. The right side is safe because you actually have your diaphragm here, so intestinal things don't go up on the right side. But on the left side, there's really nothing there. It's just your intestines, your stomach, smaller organs. And right here I wrote, a defect in the pleuroperitoneal membrane during fetal development can lead to congenital diaphragmatic hernia. In the newborn, because the liver protects the right hemidiaphragm, diaphragmatic hernias most commonly occur on the left side, resulting in displacement of the gastric fundus in the thorax. Congenital diaphragmatic hernias typically present with respiratory distress at birth, just like our question. And the reason I wrote this here is because pulmonary hypoplasia, which is what happened to the left lung, is often associated with the diaphragmatic hernia or bilateral renal agenesis if it's a question about Potter sequence. Okay, so both of those things very significant topics to understand. But memorize this image, know that it's the left pleuroperitoneal membrane that got messed up, and that's what's causing the respiratory distress in this baby right here. Right? Otherwise, this baby is actually full term, so it's not going to be neonatal respiratory distress syndrome. The only time it'll be full term with neonatal respiratory distress is probably because the mother had really bad diabetes that wasn't managed, right? So watch out for all that background information. 83. A researcher is designing a clinical trial to test a new cancer drug. In the lab, the drug has been shown to be quite effective at killing rapidly dividing cells, but it shows little effect on quiescent cells, cells that are not dividing rapidly. When the drug was given to mice, they displayed profound myelosuppression. To effectively follow patients at risk for infectious complications, it is most appropriate to include monitoring of which of the following. So basically the question is saying, when you give somebody a cancer drug, it can cause myelosuppression. To monitor myelosuppression, which of these things should you be monitoring? Now, myelosuppression is really only related to C, neutrophils. Cytotoxic T cells, natural killer cells, complement, and immunoglobulins all come from different places, and you should know where they all come from. It's very important to have that knowledge. So, a condition in which the bone marrow activity is decreased, resulting in fewer red blood cells, white blood cells, and platelets. That's what myelosuppression is. Myelosuppression is a side effect of some cancer treatments. When myelosuppression is severe, it is called myeloablation. Myelosuppression would cause all derivatives of the myeloid stem cells to be low. So what are your myeloid stem cells? That's on page 438, part of your hem-onc stuff, 398 of your actual first day 2019. So you can see your myeloid stem cell stuff, that's all of these guys. Your other answer choices are either part of your lymphoid stem cells or they're made in the liver. Right, so all of these are things that could be low. Red blood cells, platelets, eosinophils, basophils, neutrophils, and macrophages. These are all things that could be low in the patient with myelosuppression due to cancer treatment. Your lymphoblast derivatives, these are all your B cells, T cells, natural killer cells. None of those would be the correct answer, so you knock out all of those. And then complement, that's made in the liver, so that's not going to be affected either, and that's it. Right? Very straightforward question. Can definitely catch you off guard if you don't remember this topic very well, or if you don't have just a general understanding of hem-onc. So you want to make sure you actually grab that understanding very well, know where things came from. It is very significant, especially in this kind of clinical setting. 84. A 12-year-old boy is brought to the physician by his mother for a pre-sports physical exam. His mother is concerned because he's developing an enlarged left breast, and there is a family history of breast cancer. His left breast is slightly larger than the right breast, and the nipple is mildly tender. His penis appears slightly enlarged, and his pubic hair is curling and beginning to darken at its base. Findings on physical exam are otherwise unremarkable. Which of the following is the most appropriate next step? And then you look at your answer choices, and they really try to bait you into stuff here, right? Like maybe obtaining more family history is an answer choice a lot of people might pick. Explain that the findings indicate advanced physical development. That's something that you might actually end up picking because a 12-year-old guy with, they said his penis appears slightly enlarged. Well, he's 12 now. It's supposed to get bigger, bigger than when it was when he was 10, 9, 8. Order ALK, PHOS, and estrogen studies. You read this answer choice and you might start thinking of some kind of disease or something that you're not remembering maybe, and you pick it. That would be wrong too. E. Refer the patient to a specialist in adolescent medicine. He doesn't need adolescent medicine. Adolescent medicine is actually something you send someone to for treatment of like really, really significant young kid stuff. But why would you refer to a specialist in this scenario? Like, you should be able to take care of whatever the issue is. This child is actually okay. And believe it or not, that's usually the correct answer in most of these questions on NBME. Reassure the mother that the physical findings are not uncommon for his age. He's fine. The only thing that I personally didn't like about this question was, I don't know why his nipple is mildly tender. Why would his nipple be mildly tender? That's like almost never a thing. I don't know if that's part of growing, that it's supposed to be mildly tender, but I can't ever remember in my life my nipple ever being tender. So that's kind of weird. That was kind of really a thing they put into the question to bother you and really think maybe something pathological is happening. Don't fall for that, right? Generally speaking, the kid looks fine. There's really nothing wrong with him. 85. A 39-year-old man with polycystic kidney disease is brought to the physician for a follow-up exam. He has a 6-month history of intermittent blood in his urine. So that's pretty bad. His temperature is 98.6, pulse is 100, respiration is 24, blood pressure is high. Right? That's high blood pressure. That's actually pretty bad high blood pressure. The systolic is very high. Physical exam shows no other abnormalities. His serum urea nitrogen concentration is 100, creatinine is 8, so he has really bad kidney issues. Right? That pretty much sounds like kidney failure right there. Urinalysis shows blood. Arterial blood gas analysis on room air is most likely to show which of the following sets of findings. Start studying your acid-base physiology very, very hard. It's in NBME. It's on step 1. They love asking questions about it. And it's always going to be very confusing to you if you haven't mastered acid-base physiology. Because you look at these answer choices, at the very least, maybe you'll know the pH, but then you're going to get very confused about CO2 and bicarb. You just won't know. There are so many different scenarios that you have to know the arterial blood gas analysis for, and it takes time, but you really have to master all of those topics. Renal is actually very difficult because of that one section. That one section ties in with the entire book, right? Because there are diseases on that one page that are related to everything. So I have notes here for all the different things, right? Because look at all the different diseases that are mentioned on this one page. And this image over here on the right, this is another thing they love using. UWorld has questions where they use it too. You get questions where this table or something from this page gets asked about, and then you get answer choices very similar to the one we have here. pH, PCO2, bicarb, it could be anything else. You really need to know it very well. So this guy, our guy here, actually has kidney failure, right? So his labs show he clearly has kidney failure, so there will be defects in reabsorption. This means he's not reabsorbing bicarbonate, so his bicarbonate should be very low. Normal is 24, right? 20 to 28. The only answer choices here that have low are A and D. So congrats, you're down to 2 answer choices. You knocked out B, C, and E. Since he's failing to reabsorb bicarbonate, he's going to be in metabolic acidosis, right? Because bicarb is an alkaline thing. So he's going to have metabolic acidosis. The body tries to make up for this by blowing off CO2, by breathing really, really hard and stuff. But it's really not going to be that strong of a compensation. Blowing off CO2 doesn't fix the metabolic issue of not having enough bicarbonate. It only compensates a little bit. Right? So the respiratory compensatory mechanism for metabolic acidosis, which is hyperventilation to blow off CO2, is not going to overcompensate for the primary defect. That is, he's not going to hyperventilate so much that the pH actually ends up slightly above normal, which is answer choice D. Right? So that means that it must be A. So you have to be able to reason through these things. It's not even just memorization. The memorization, at the very least, is knowing if it's acidosis or alkalosis. But acid-base physiology is very hard because we have compensatory mechanisms. So although something might have been acidosis in the beginning, it might actually have normalized, and you have to be able to figure out how to, resolve that, how to figure that out, how to put that into an answer choice. There are so many things that cause metabolic acidosis and alkalosis, like Addison and Kahn. Right? You have to know the actual shifts of electrolytes in them. So that's kind of stuff I'm listing out here. Main point is, eventually you should be able to print out this page and then look at each one of these things: airway obstruction, acute lung disease, chronic lung disease, anxiety, whatever it might be, and reason out what should be wrong with the pH, PCO2, and bicarbonate with each of these patients, and then any other electrolyte abnormalities that they should possibly have. The electrolyte abnormalities become even more significant when you're looking at the mud piles things, right? Because here you have an increased anion gap, which might be the differentiating factor between 2 answer choices, one with the normal, the other with the increased. On the cheat sheet that I've made, I've actually put mud piles and hard as there, so I could remember which one's the anion gap and which ones are normal. But in general, you really want to make sure you spend a lot of time on this, spend an entire week on it if you have to make sure you really can reason through all of these, right? So if you're doing opioids, for example, opioids means that's respiratory depression, so I'm not going to be breathing out much, which means I'm going to retain all my CO2, right? And I don't have this written on the page right now. I'm telling you how you should be able to reason this. So opioids, not breathing fast, a lot of CO2 gets retained, so PCO2 is going to be high. If PCO2 is high, you're going to have respiratory acidosis. Now, for respiratory acidosis, remember that all your respiratory things, right, respiratory acidosis and alkalosis, the compensation is delayed. Respiratory things have delayed compensation. You have to remember that. However, the compensation is going to involve fixing things with bicarbonate, right? Because if your issue was respiratory, then compensation has to be metabolic. The same is true both ways. If your issue is metabolic, the compensation has to be respiratory. And respiratory compensations are fast because you can breathe fast. You can just fix your breathing rate really, really quickly. Metabolic things, you can't really fix that quickly. So if you have a respiratory issue, like respiratory acidosis, the metabolic compensation is going to take time to kick in. And that compensation, in a case of acidosis, that compensation must be that I'm going to try to keep my bicarbonate, right? So I'm going to have high bicarb, high PCO2, low pH. Right? You should be able to reason it out, print this page out, reason out each one of these issues, such that if you ever get a question on any of them, you know why each of the labs have to be the way they have to be, and you can pick out the correct answer. Right? If you don't spend time like that, in that manner, doing that, then hopefully you have another way of memorizing that in a good way, because that would be my best suggestion for memorizing acid-base physiology. I don't know what else you could possibly do. You could do many things, but I don't know how effective those other methods might be. So if you have a better method, definitely go for it and do it. Share it with me if you can, and I'll tell other students about it too. 86. An investigator is studying a vancomycin-resistant strain of Enterococcus faecalis cultured in a liquid medium. 10 generations are propagated. Right, so it's vancomycin-resistant Enterococcus. They make 10 generations of it. The culture is then inoculated onto a solid medium lacking vancomycin. Right, so now they put it, even though it's vancomycin-resistant, they put it in a medium that doesn't have vancomycin. The resulting bacterial colonies are subsequently screened for vancomycin resistance using replica plating. Vancomycin-sensitive colonies are observed at a frequency of 1 per 100. So although they were all initially, the first generation was initially vancomycin-resistant, the newer generations are somehow vancomycin-sensitive, right? Which of the following mechanisms best explains the decreased vancomycin resistance in these resulting colonies? And you look at your answer choices and you know immediately this is about bacterial genetics. Now, you cannot freak out when you see something like this, right? You should understand that somehow these bacteria lost the genes that allowed them to be resistant to vancomycin, right? That much is understandable. Gene duplication will not help you lose a gene, so that can't be the answer choice. Gene insertion is not going to turn off necessarily the other genes you already had for vancomycin resistance. That doesn't make sense. C is a possibility. A point mutation can definitely mess up a gene and then you're no longer resistant. That can happen. Transposition is another possibility. Now, coming back to the whole concept of point mutation, you should understand that mutations are not inheritable, right? Just because one bacterial colony might have had a mutation in a couple of them doesn't mean they're all going to have it, right? However, we do kind of see that not all of them do have it, right? Only 1 per 100 cells in all these colonies have it, but there were 10 generations. 10 generations. It shouldn't be 1 per 100 cells. That's actually a lot still. That's 10%. That's 1%. And 1% of 10 generations, that's 10% practically, right? So that's a lot. A point mutation would not propagate that badly. It really wouldn't. So that's not a plausible answer choice per se. So between transposition and plasmid loss, transposition is really just transposition. You're moving the position of some genes from one place to another. You won't lose resistance because you moved the gene around. So the only answer choice that shows any kind of loss was C, and that was the only reason I picked it. I didn't actually remember what's on this page. So page 131 actually talks about this exact question, right? Transposition, a jumping process involving a transposon which can copy and excise itself and then insert into the same DNA molecule or an unrelated DNA. Critical in creating plasmids with multiple drug resistance and transfer across species line, such as vancomycin resistance from Enterococcus to S. aureus, if you plate them together. So that's another question you can have, right? Where they plated vancomycin resistant Enterococcus with some Staph aureus that was susceptible to vancomycin. Later on, that S. aureus also became very resistant to vancomycin. That's actually because of transposition. Somehow, a transposon from a plasmid was taken from vancomycin resistant Enterococcus and put into vancomycin sensitive Staph aureus. That's a really simple topic here. Not something that's very high yield, so you might not actually recall having studied it. You might not even remember this page, because I definitely didn't remember this page much. But the main idea is, in these answer choices, it wasn't too hard to cancel things out and understand that, the main concept is these guys lost a gene. The only way you could lose a gene from these answer choices was really just C, plasmid loss. 87. So again, we see the anion gap and all these things in pH, right? Very high yield topic, acid-base physiology. 35-year-old woman is brought to the emergency department by her husband because she passed out while washing dishes. The patient says she began to feel weak and dizzy but does not remember anything else. While the nursing staff is checking her vital signs and drawing blood, the husband tells the physician that the patient has bulimia nervosa and she has been binging more frequently over the past 3 weeks. He suspects that she has been vomiting, which was a sentence that was very unnecessary. But I guess binging, it could have been just binge eating, so that's why they tell you this, right? So yeah, it wasn't unnecessary. Yeah, it could be binge eating too. So she's been binging, binge vomiting a lot. Which of the following patterns of abnormal lab test results most likely indicates recurrent vomiting in this patient? And you don't even need the whole scenario. If you just read that last sentence, you would know exactly what the question is and you could pick an answer choice. So recurrent vomiting. So if you're vomiting a lot, right, what's supposed to happen? Well, if you're vomiting a lot, you're going to lose acid. That much is obviously very evident, right? If you're vomiting a lot, you have acid in your stomach, you lost it. So if all the answer choices where pH is low, you can cancel out B, C, and D. So again, congrats, you're down to just 2 answer choices, A and E, right? You lost all your acid. The answer choices made this easy because A is the only one with high bicarbonate, which is expected. That's it. This was a very, very easy question, right? In recurrent vomiting, vomiting causes hypochloremic, hypokalemic, metabolic alkalosis. Metabolic alkalosis is metabolic, which means bicarb is going to be high, especially in relation to the HCl you lost, right? And this is the same labs that you also see in hypertrophic pyloric stenosis in infants. So that's where you get this kind of question from. Right, but very easy question because the answer choices were just easy to knock out. Again, it's not entirely memorization, the acid-base physiology page, it's understanding. You should be able to reason out where the electrolytes should be, what the lab should look like, because it's just a reasonable thing. None of that is just really memorization. Some of it is memorization, like you have to memorize, what do loop diuretics do for this section, right? What does hyperaldosteronism do? Con, so that's why I put this here. Right, you have to know like acetazolamide, spironolactone, right? Some of these medications you have to memorize some of those things for sure. You have to know how everything works to be able to reason out what kind of acidosis or alkalosis you would have. But generally speaking, it's all about reasoning. 88 was a great easy question too. 65-year-old woman comes to the physician because of a 1-week history of a swollen, painful left knee. So you're thinking some kind of gout. Her temperature is pretty high. Blood pressure is 110. Examination of the left knee shows erythema and swelling of the joint and decreased range of motion. A photomicrograph of synovial fluid obtained by arthrocentesis is shown. This patient's synovial fluid most likely contains which of the following? So when you look at this image, the only thing that should really stick out to you is this stick, this needle thing here, right? The rest of these are just all neutrophils, right? You have some other cells in between, but generally speaking, there's a bunch of neutrophils, which is expected, and you have this one needle-like thing here. There should have been more than one, but whatever. And then you look at your answer choices. Now, hydroxyapatite, lymphocytes, Neisseria gonorrhea, treponema pallidum, and uric acid. The answer choice that was a bait here was the lymphocytes. If you don't quite remember the correct shape and size and color of all your white blood cells, you might have thought some of these are lymphocytes here and you should just pick it, that's expected or something, and you would pick it. That's the wrong answer. This actually is uric acid, right? That's a giant urate crystal. This is just not your typical image. Your typical image would have been under polarized light. So you would see something like this image right here, right? But this, I put it here now, this is the image they gave you in that NBME 18 question, right? With gout, you're supposed to see negative birefringent under polarized light, which means it's yellow under parallel light. Right? And that's the yellow under parallel, blue under perpendicular. Calcium pyrophosphate deposition doesn't have needles. It has these rhomboid kind of things. Okay, so that's a whole different thing right there. And if it was septic arthritis, then you would have seen gonorrhea. You would see tiny intracellular bacteria, right? Because Neisseria goes inside the white blood cells. So that's all irrelevant for our patient. Our patient literally just has a needle right there. That's the uric acid needle. Typical gout. 89. An 83-year-old woman with systemic arteriosclerosis undergoes repair of an 8 cm infrarenal abdominal aortic aneurysm. A prosthetic endograft is inserted in the femoral artery, threaded up the aorta, and then expanded when in place. All right, so they're giving you a pretty nice pathway that it's taking. The graft extends from just below the renal arteries to the bifurcation of the aorta. Because of the position of the graft, which of the following organs is most likely to lose its primary blood supply and subsequently must rely on collateral circulation? So this is a straight up question about the abdominal aorta. Very straightforward, very easy. Don't get too confused. They put this graft, right, and it came all the way to where do they say it extends all the way below the renal arteries to the bifurcation of the aorta. All right, because of the position of the graft, which of the following organs may lose primary blood supply? So if we remember the actual organization of arteries on our aorta, then look, they're coming all the way down to here, the bifurcation, right? So you have your inferior mesenteric artery, superior mesenteric artery, and celiac. The inferior mesenteric artery is the only one here that's below the renal. Okay, the superior mesenteric and celiac are above the renal. So in our question, they will not be affected. The inferior one will be affected, which means that anything that the celiac supplies is going to be okay. So the spleen, the pancreas, the duodenum, liver, stomach, that's going to be okay. And then for your superior mesenteric, so your what are you saying? The ileal parts and then your colon, that's going to be okay. But your inferior mesenteric stuff, right? Hold on, give me a second. Wasn't that supposed? This is your superior mesenteric stuff. And then, yeah, here you go, the inferior mesenteric, right? Because remember, they have collateral supply at the cannon point. Superior takes care of all of this. Inferior takes care of the latter half of your transverse colon, descending colon, up to the upper portion of the rectum. So you look at all your answer choices, and the only one that fits is B, descending colon. Your inferior mesenteric artery can actually lose blood supply because of the procedure they did. That's all this question was really about. Everything else is above the level of the renal arteries, and those will not be affected. All right. And then look, again, another acid-base physiology question in the same block. Right, this is the third one right now. 14-year-old girl with type 1 diabetes is brought to the emergency department because of a 4-hour history of lethargy, confusion, disorientation. She has vomited twice during this period, and she says she is thirsty and that her stomach hurts. Symptoms developed gradually overnight after she did not take her usual insulin dose during a sleepover at her friend's house. Her pulse is 110, respiration is at 24, and rapid. Blood pressure is low. Lab studies show glucose concentration of 450 and arterial pH is 7.15. So that's all a sign of diabetic ketoacidosis, which is what happens when you don't take your insulin, right? Arterial blood gas analysis is going to show you what? So this one you really need to know. This is a very high yield topic. In diabetic ketoacidosis, you're going to have a high anion gap metabolic acidosis. Since it's going to be a high anion gap, you can knock out all the answer choices that are normal anion gap, right? This is actually let me go back to, right, of your high anion gap, this is the D of mud piles, diabetic ketoacidosis. Right, very important to remember that. So high anion gap, so you're really just down to 3 answer choices now. And then since it's a metabolic acidosis, and you know it's metabolic acidosis because this has nothing to do with the respiratory issue, if it's metabolic acidosis, that means your bicarb must be low. The reason you have this acidosis is because you lost bicarb. So if bicarb is low, then you're going to have respiratory compensation. Respiratory stuff is very quick. You can fix it instantly. If I tell you to breathe quick, you'll breathe quick. If I tell you to breathe slowly, you'll breathe very slowly. So it's going to have immediate compensation with respiratory compensation. So you're going to, PaCO2 will immediately decrease because you have acidosis, so you're going to start breathing fast to really get all that out. They even tell you that, right? 24 per minute, deep, rapid breathing. That's the compensation she's doing. So after all that, it was really easy to just pick F, right? PaCO2 better be low because you're breathing really fast to fix the metabolic acidosis. Bicarb is going to be low because that is what metabolic acidosis is. and it's going to have a high anion gap. Alright, that's it. '91. So here we have a 71-year-old man with prostate cancer is admitted to the hospital for a prostatic resection. On admission, his mental status is normal. 2 days after the operation, he's confused and restless. He complains that he cannot sleep because little men are coming through his window at night. Which of the following is the most likely diagnosis? And we just talked about this in first aid in my psych videos that we're up to right now, right? This is classic delirium, very classic delirium. Elderly patients that come in for any kind of hospitalization, especially in the ICU, you're going to have cases of delirium in them. Nurses have an actual phrase for this. I didn't know about it until I made a couple friends that are nurses. They call this sundowning. Sundowning is a thing. So after the sun goes down, a lot of patients that are elderly start acting very delirious. They'll start, throwing tantrums, saying they want to go home, saying no one cares about them, no one's taking care of them, blah, blah, just complaining nonstop. That's called sundowning. Sundowning is delirium. They're the same kind of thing. Very common thing. Very, very common thing. So you want to make sure you know it. This is not dementia. Remember that delirium is acute, and delirium is reversible, right? It's acute. It's due to some kind of underlying issue. Here, the underlying issue was, the prostate cancer treatment. The patient got stressed out, got delirious. And it's reversible. As soon as the issues go away, the patient starts getting better. So this patient, is just going to need supported treatment. Eventually it's going to get better. Make sure you do not give things that will make things worse, right? So we talked about that. Do not give medications that would make this delirium worse, right? If you give them anticholinergics, benzodiazepines, or opioids, because of any of the things they're complaining about, you're going to make the delirium far worse. Alright, otherwise it's just a waxing waning level of consciousness. Very, very common with elderly patients going through some kind of inpatient procedure. Man, I'm like burping like crazy because I'm starving. Intermittent fasting. Excuse me. Alright, so dementia in comparison is actually chronic. It's a progressive loss of memory, right? Progressive loss of memory, very similar to Alzheimer's, and it's usually irreversible. It's only reversible if it's due to something that you can fix, like hypothyroidism, B12 deficiency, anything else like that. And then the other answer is this didn't make any sense. This is not a brief psychotic disorder. This is not schizophrenia. And this is not a delusional disorder. That was another thing we talked about, right? Delusional. Delusions is psychosis, right? False fixed beliefs. This guy doesn't have a false fixed belief. This guy has acute delirium. 92. A 62-year-old man with angina pectoris is referred for diagnostic cardiac catheterization. The patient is concerned about his risk for acquiring a hospital-associated infection if he undergoes the procedure. Previous studies have shown that 30% of patients require admission to the hospital following this procedure, and 2% of those admitted patients end up getting a hospital-associated infection. If this patient decides to have the procedure, his risk for acquiring a hospital-associated infection is just straight-up math. According to previous data, he has a 30% chance of being admitted, and a compounding 2% chance of getting infection if he's admitted. So 0.3 times 0.02 is 0.006. So it's a 6 out of 1,000 chance of getting infection from the hospital due to an admission because of the procedure. Right? Very, very tiny chance, which makes sense. It shouldn't be a big chance. That would suck. 93. A 17-year-old boy is brought to the physician by his mother because she's concerned about his physical development. She says that he is not developing the way his 2 older brothers did. He has no history of major medical illness. He is at the 10th percentile for height and 25th percentile for weight, which is really just useless information. Honestly, that doesn't tell you anything. There are so many questions where they'll put stuff like that. At this point, they might as well just say he's at like the first percentile for height and first percentile for weight, and it's still going to be a perfectly normal child. That's like a thing they do in NBME. This sentence is really irrelevant. Doesn't tell you anything. Serum studies show a FSH concentration of 5 and testosterone concentration of 8, which is below normal. So now you know something's definitely wrong with this kid. Which of the following physical findings is most likely in this patient? Well, it's a 17-year-old boy, right? And FSH is high. That FSH thing should immediately remind you of Klinefelter syndrome. The 17-year-old boy has low testosterone but is otherwise well. The answer choices hint at a sex chromosome disorder. For low testosterone, it is most likely the patient has Klinefelter 47XXY. Enlarged testes are seen in Fragile X syndrome, and excess body hair, strong muscles, and low-pitched voice are pretty irrelevant things. So here the correct answer was just C, gynecomastia, right? Because of the XX part of XXY. So that's the reason you would be able to come to that answer choice is because the FSH thing. Right? These guys have high FSH, high LH, low testosterone, high estrogen. Very important to remember that. This was actually a snippet from the correct answer choice of a URO question regarding Klinefelter. Right, so make sure you remember those labs. You can get easy questions on it. Right? And the other answer choices should always be stuff you know too. Enlarged testes is a part of the Fragile X syndrome stuff. The other things are just not really a sign of anything major. This question was pretty interesting. I actually, let me see this one. Yeah, I actually didn't entirely know what was happening like in terms of the correct answer, but I did guess and I did get it correctly because I felt like it was pretty obvious. But at the same time, I could see how people could have picked something else. So a 64-year-old man with non-Hodgkin lymphoma comes to the physician because of a 3-day history of abdominal pain and nausea. His temperature is high, pulse is 100, blood pressure is okay. Abdominal exam shows tenderness of the flanks and left and right lower quadrants. Serum studies show urea nitrogen at 34, creatinine at 3.8, so he's having renal issues. An abdominal CT shows bilateral hydronephrosis and lymphadenopathy compressing the ureters. Placement of which of the following is most likely to improve this patient's renal function? So I saw the answer choice C, bilateral stents in the ureters, and I just picked it. I didn't really spend much time on it. But then I went and checked everything, and I found it was correct, and I found images to kind of show what these other things look like. So both ureters are compressed, causing urine to back up and leading to hydronephrosis. Bilateral stents in the ureters will allow the urine to flow, and you could actually pee now. Suprapubic tubes drain urine from the bladder and are used in urethral trauma. If the exit is not working, right? If the exit is not working, then you do this. This is a suprapubic, right? It's above the pubic symphysis, suprapubic tube, right? And then you can just connect that to a bag outside and let the patient pee, right? That's one thing. But this wouldn't be necessary for our patient because our patient's urethra should be okay. So the urethra is alright, so then you can just put a stent in and let the urine drain. The issue with this patient was pressure on the ureter. The Foley catheter answer choice A, is pretty much the same thing too. That's also the same thing, suprapubic tube, a Foley catheter. So again, unnecessary stuff. This patient just needed stents. Right? And the left renal artery and right renal arteries thing was just filler answer choices, completely irrelevant, doesn't make any sense. Last few questions for block. What is this? This is block 2. Block 2, 95. A 34-year-old man is brought to the emergency department, semi-conscious and combative. In addition to sedation, a short-acting neuromuscular blocking agent is administered for intubation to prevent aspiration. Within a few seconds after administration of the drug, he has transient muscle fasciculations in his face. He develops generalized paralysis within 1 minute. 45 minutes after completion of the procedure, he is still paralyzed. And we just talked about this as well in the psych videos. In the neuropharm, right? A genetic abnormality of which of the following enzymes is most likely cause of his unusual paralysis? And I already knew before picking or even looking at the answer choices. It's acetylcholinesterase, right? This is the same as plasmacholinesterase, which metabolizes succinylcholine. That's what this patient was given. Neuromuscular blocking agent. Very straightforward. Page 595. We just talked about this in my neuropharmacology videos. So succinylcholine is the depolarizing neuromuscular blocking drug. It has two phases. Phase 1 is the prolonged depolarization, so you can't do anything here. And if you give a cholinesterase inhibitor, you allow more acetylcholine to be available, but nothing, the block gets potentiated by the cholinesterase inhibitor. If you stop the cholinesterase, you have more acetylcholine available, and it prolongs the depolarization even more. Phase 2 is repolarized but blocked. Acetylcholine receptors are available but desensitized. And this phase may be reversed with cholinesterase inhibitors, because now when you have acetylcholine available, the acetylcholine receptors are available, so things might start working again. But phase 1 you can't reverse. And this stuff always gets tested by the train of 4 stimulation, TOF. And you have to make sure you know what TOF is about, what that looks like, how that helps you differentiate between succinylcholine versus a non-depolarizing block, vicuronium or any of those other uronium medications. Right, very important topic. Make sure you spend some time on it, understand it, memorize it. Don't really need to come back to it again. Just know it, so that if you see it in the question, you will know how to tackle it. '96. This one was actually really easy too, especially with the image given. It's a 25-year-old woman comes to the physician because of fatigue for 3 weeks. She had intermittent fever in the past 7 days. She had her teeth cleaned 1 month ago, but she didn't receive any prophylactic antibiotics. Now, with teeth cleaning, you don't necessarily need antibiotics, but if you get a dental procedure, like getting your teeth pulled out, then you do need antibiotics. So that was a little bit of, NBME bullshit right there. She had rheumatic fever as a child and had an episode of endocarditis 4 years ago. So she basically has damage to her valves. A grade 2 out of 6 murmur is heard on auscultation. Ultrasonography shows an abnormal mitral valve, which makes sense because, rheumatic fever. A photomicrograph of the causal organism grown in blood cultures is shown. The causal organism will most likely demonstrate which of the following. So you needed to know immediately after the question scenario of dental procedure versus cardiac issues is given. That's strep viridans. Strep viridans, if you remember the sketchy microimage, is actually drawn with strep pneumo. They're both together, and this is the alpha night tournament. This is alpha hemolytic, which is going to cause greening reaction on blood agar. Straightforward stuff. You should also be able to knock out the other answer choices. Resistance to novobiacin is actually related to Staph saprophyticus because her navel is hidden in the sketchy microimages. Susceptibility to bacitracin, right? Bacitracin susceptible. Remember, let's go back and take a look at it real quick. Thanks a lot, Noaz. I'm from India. I'm actually from India. Page 137. Okay, so this is the image we need to look at for our guy. Right, so this is strep pneumo, the pneumonite, and the jester here for the viridans night, right? And you can see his hat has the heart on it. That's a mitre hat. It's supposed to tell you about the mitral valve. He has bile insolubility, so he has those bile chutes. He's not going to be affected by bile. Strep pneumo is. He's holding a deck of cards because they use dextran, right? Dextran to adhere to platelets. So his shield is a platelet. Dextran is to adhere to platelets on previously damaged heart valves, and that causes subacute endocarditis. Acute endocarditis would be from Staph aureus, which is very, very bad. So that was something that you could get straight up from sketchy microimages. Staph saprophyticus is the one that has, the whole concept of novobiacin. So you can see this image is both of them, saprophyticus and epidermidis. Epidermidis is the guy working on fake valves down here, right? So you got the heart valve and pipes and all of that, and you have the adhering and whatnot. His navel is showing, so he's novobiacin sensitive. Her navel is not showing, so she's novobiacin resistant. That was the thing seen over there. Bacitracin was the one with the Basset hound, right? So this is the Basset hound right here. You can see he's actually able to lick the food. So strep pyogenes is bacitracin sensitive, right? This is a Basset hound, the dog, and the dog is licking the food successfully. So it's Basset sensitive, bacitracin. Whereas strep agalactiae is bacitracin resistant because here the dog can't lick him. He's stuck in the alien helmet, you know, or the astronaut helmet. So very important things to memorize, very easy to memorize with sketchy micro. So that was it for this question. Straightforward, just memorization stuff. If you don't remember it, then you're pretty lost on that. This is again some of the stuff from Neuropharm. So 56-year-old woman brought to the emergency department after she was exposed to possible chemical attack at a train station. Her respiration is labored. Physical exam shows diaphoresis, lacrimation, and salivation. So all the fluids are coming out, which is very much like organophosphate poisoning. Muscle strength is low. Urinary and fecal incontinence is also there because she's probably urinating and has diarrhea. In addition to atropine, which of the following drugs is most likely appropriate? So by telling you that they gave atropine, they're pretty much confirming this is anticholinesterase poisoning. So the only other medication related to this issue of organophosphate or anticholinesterase poisoning, you're supposed to give pralidoxime. You have to know this topic. UWorld asked you about this too. Step 1 is definitely going to test you on this. Very important topic because there's two things that you need to reverse. So your muscarinic effects are the ones related to acetylcholine. That gets reversed by atropine, a competitive inhibitor, right? Because how do you get these muscarinic effects? Well, you took an acetylcholine esterase inhibitor, which means you have too much acetylcholine. All of that acetylcholine is going to work on mainly the M3 receptor, leading to all these symptoms. So you have to stop that by giving an acetylcholine antagonist, right? Competitive inhibitor like atropine. The nicotinic effects, however, like your neuromuscular blockade, that gets reversed by pralidoxime because it regenerates acetylcholinesterase. But you have to give it pretty early. You can't take too long in giving that. Okay, very important topic right there. So pralidoxime. The other answer choices didn't have anything to do with anticholinesterase poisoning. They are of a similar chapter, but not for anticholinesterase poisoning. 98 is Cushing again. They love talking about it. So this is actually a very interesting question. So a 45-year-old man comes to the physician because of an enlarging face. So an enlarging face, shoulders and trunk, and thinning of his arms and legs. Physical exam shows a round, plethoric face, fat pad over the upper thoracic spine, and purple striae on the abdomen. Serum studies show an undetectable ACTH concentration and an increased cortisol concentration. Administration of low-dose dexamethasone would most likely cause what? So remember when you do the Cushing test to check for everything, if their ACTH is low, then you don't do the dexamethasone or the CRA stimulation test. Those are things you do when the ACTH is high. If ACTH is low and you still have Cushing, that means that your adrenal gland is making a lot of cortisol for no reason whatsoever. You must have an adrenal adenoma. Right now, giving low-dose dexamethasone will not suppress ACTH secretion because it's already low to begin with. Right? However, keep one thing in mind though: the CRH stimulation test would cause a change. If you give CRH stimulation, CRH is going to correctly cause you to release more ACTH. However, the amount of ACTH you'll be releasing is not going to be crazy high because it was very low to begin with, right? But the main point is you don't do those tests if ACTH was low to begin with, right? So if we go to endocrine path again, and you can see right here, first thing you do is measure cortisol, right? And then you measure ACTH. If ACTH is high, then you do these other things. Right, because now you have to figure out where the ACTH is coming from. Is it the pituitary or is it from a lung cancer? If it's the pituitary, that's part of the HPA axis, hypothalamic pituitary adrenal axis. Dexamethasone and CRH will actually have effects of feedback on that axis. If it's from the lung, there will be no feedback, and that's bad prognosis. You have lung cancer, right? Those two. If your ACTH is low, then you have an ACTH-independent Cushing syndrome because you're either eating corticosteroids or you have an adrenal gland tumor that's making too much cortisol. Very simple, straightforward topic. All right. But the cool thing here was I did want you guys to understand that CRH stimulation will cause stimulation. This is dexamethasone suppression. Doesn't have anything to suppress, so there won't be any suppression because already the ACTH is very low. Last two questions. My email is in all of my videos. Let me put it for you right here. And okay, last two questions to wrap this up for today. First, okay, 99 was really easy. This was just stupid. 16-year-old girl calls the physician on a Friday night 2 hours after a condom broke during sexual intercourse with her boyfriend. She asked the physician to prescribe an emergency oral contraceptive. The physician on call is not the patient's regular physician and does not dispense emergency contraceptions for moral reasons. After the physician respectfully informs the patient that he does not prescribe this contraceptive, it is most appropriate for the physician to state which of the following. First of all, right, you shouldn't have such moral things affecting your career, right? That's just, it's silly. I firmly believe that if you do have certain moral beliefs, either regarding contraception, abortion, or if you have strong moral beliefs against homosexuality, anything weird like that, you're not exactly 100% fit to be a doctor, because you can't let your personal beliefs determine whether or not you treat a patient. That's terrible. That's stupid. That's very immature and unrealistic. However, it is still a realistic thing that does occur. There are many people I know that are in their years of residency right now, because they were 2 years ahead of me in med school, that would always talk about how they would never treat a homosexual patient because they're just that strong of a Catholic. Such a strong Catholic that they'll rather let people die than help and carry out their job, right? What a great religious human being. That's bullshit right there. And then having moral beliefs against contraception, great. So that means you won't use contraception, your wife won't use contraception, your kids won't use contraception, but you're not supposed to shove your own personal beliefs down other people's throats, right? The concept is real. Keep your dick to yourself. Don't go shove your dick in everyone's throat, right? Do that. If you have certain moral beliefs against something, you keep it to yourself. You can act on it however you want, but you don't force everyone else to believe it, where you're going to have this 16-year-old girl get pregnant instead. You know, it's really silly. That's very, very silly stuff, but it's reality and you can't do anything. You know, you can't really punish this kind of behavior. But how is someone, you know, like this guy really supposed to deal with it? So, okay, he has a very strong moral belief. How is he going to really deal with it? He better find her another physician that can actually give that medication, right? Give the oral contraceptive. So here, right, the most appropriate thing to do was B. I can have one of my colleagues call you back to further discuss your concerns. But look at the dates too. It's Friday night, 2 hours after they just did this, right? So it just happened. You have about 24 to 48 hours to deal with this before the fertilization and implantation occur. So other answer choices really didn't make any sense. I'm obligated to discuss this with your parents. It's completely silly. I recommend that you call the local women's health clinic. Completely unrelated. I will tell your regular physician to call you on Monday. That doesn't work because by Monday, it's going to be too late. And then E, I'm sorry, but you will have to research other ways to obtain the prescription yourself is never the answer you give about anything. Last question, number 100. A 38-year-old man comes to the physician because of a 1-week history of shortness of breath with exertion. His respiration is at 12 per minute. Light palpation of the carotid artery shows the upstroke to be abnormally brisk and the downstroke to fall precipitously. Which of the following is the most likely cause of the physical exam findings? This question got so many people confused. But this is actually something that, again, with, you know, general medical knowledge, you should be able to tackle. First of all, they're talking about the carotid artery, right? So if they're talking about the carotid artery, this most likely has something to do with your aorta, right? The ascending aorta going to the carotid artery area. So you can knock out D, E, and F. It's probably not one of them. Now, if it was aortic stenosis, we would probably expect an older patient, right? And look at what they're describing. Upstroke is abnormally brisk, and downstroke occurs precipitously, which means it just occurs a little too early, it occurs too quickly. So that means that blood is going through the aortic valve into the carotid briskly, and then all of a sudden goes backwards. That sounds like aortic regurgitation. and that's exactly what that was. This is actually describing something called the where is it? I didn't put it here. Alright, let's take a look at it then. Page 300, 301, and 304. Water hammer pulse, I think, something like that. We'll take a look at that. So aortic regurgitation has this image, right? You have to remember how the graphs look. You always have to spend some time to make sure you know how the graphs look. You have to memorize it once and for all and never really need it again. You should understand the axes and know exactly what's happening right after that. It's really not a memorization thing. It's a graph. Graphs are meant to be read. You should be able to read it and understand what's happening. That's one thing. Then you have the U-road stuff, aortic regurgitation, same thing. So I gave more of a breakdown of what's happening. And here, right, when you look at this stuff, so this is what's happening with our patient. Right, it's called a water hammer pulse. Water hammer pulse in aortic regurgitation. You get this concept of like blood kind of making. Water hammer is actually, so if you have like a full bottle of water, you do this. That's what a water hammer pulse is. It's that sound. Now, if there was more water in here, it would do a better job with it. But you hear this kind of swishing, right? That's what a water hammer pulse is. You're not supposed to hear that. And you can see how, it's rhythmic, up, down, up, down, up, down, rather than the normal stuff of, something like this happening. So water hammer pulse is what they were describing here, and it really wasn't that hard to pick it. But a lot of people were just completely lost because this description that they gave is pretty rare. And then this link also shows you a lot more, tells you a lot more about this kind of physical exam finding and about aortic regurgitation, which is very high yield. So make sure you understand that stuff. And that's it for block 2. And the next video will go on continuing block 3, and we'll do that stuff. So I'll see you guys later tomorrow to continue on NBME 18.